So a little bit more from me here. We'll talk next just about infection rates and some more about transmission. So as we've kind of been mentioning all along, HPV infection is really very common. There are about 14 million new infections a year in the U.S. At any given time in the U.S. population, there have been a couple different studies done looking at this. But as Aaron was talking about taking swabs to check for oral HPV, there have also been numerous studies done looking at genital HPV, so taking swabs inside the vagina, from the cervix, in men along the shaft of the penis or the scrotum. And depending on what study you're looking at and what age group and what demographic, at any given point in time, there are higher numbers of people who will have a genital infection. So anywhere from a fourth to 42% of the population, you can do a swab and find genital HPV. And again, the vast majority of these people have absolutely no symptoms. They have no idea they have this, and they never will. Most people will clear it and have, no idea unless they have an abnormal pap or something else. So about 80 million people with current infections, and lifetime risk we know is at least 80% that you'll get an infection. It's probably closer to 90, I would say. It's extremely easy to transmit HPV. It's transmitted just by skin-to-skin contact alone. So when we think about the plantar warts that happen on people's hands or feet, it's just skin contact. If you touch someone with the wart, you can also get a wart on your hand or foot. Genital contact is really the same thing. It's shed from all of those places that I mentioned in the genital areas, and so because condoms don't cover all of those areas, for example the scrotum or the labia, they only provide about 60% protection against HPV. I'm an OB/GYN, so I'm still going to tell you, hey, use condoms, you don't want to get chlamydia or other things, but just good to know that it still can be transmitted despite condom use. I think Aaron kind of briefly mentioned oral to genital transmission, and this is Michael Douglas here, who was in the media a couple of years ago. He was talking about how he got his oropharyngeal cancer from performing oral sex on his wife, and I don't know that he can blame Catherine Zeta-Jones necessarily. It might have been a previous partner, but we do know that oral to genital transmission does happen. So now I'll talk about vaccination next, because, hey, this is great. We can prevent cancers by giving a vaccine. I just want to say that again because I think it's so important. We can prevent cancer with a vaccine. I think that's really awesome. So I wanted to back up and first just talk about how vaccines work, because every year around this time I'm trying to give my pregnant ladies flu shots, and once or twice a week I'll have somebody who says, well, Dr. Bradley, I don't want the flu shot because that's going to give me the flu, or I get the flu from the flu shot. So I just included these couple of slides to talk about how vaccines work. So when we think about natural immunity, when you get infected with a virus, what happens is that your body makes these antibodies, which are the body's defense system. I kind of think of these as almost like Pac-Man cells, and I have this idea in my mind of them sort of eating up and chewing up and spitting out the virus and getting rid of it for you. That's kind of how those antibody cells work. So when we give you a vaccine, what we do is we're having synthetic or man-made particles that are injected into your system. So if you look at these little triangle particles here, I intended for those to look like these little spikes here on this virus. So basically you're being injected with this particle that looks like part of the virus but is not actually the virus. And then what happens is that stimulates your body to make these antibody cells to recognize that foreign particle, and then once your body's had that exposure, the next time it's exposed to something like this, it will remember that virus or that type of particle, and then it will respond much more quickly and have a much greater response. So again, if you're infected with these same three viral particles, your body's immune system, it's making all these antibodies much faster rate and a much greater amount or number of antibodies. So that's how a vaccine works. Hopefully that makes sense to everybody. So next I'll talk about effectiveness. So this is some of the original data, and I'll just kind of go through and talk about how some of these studies were done. This is looking specifically at vaccine effectiveness in women at 4 years, so meaning they got either the vaccine or placebo, and then they had testing over the next 4 years to look at effectiveness. These studies were done in a college-age cohort of women, so women who were around 18 to 23 or so, and these women were randomized to either getting the vaccine or getting a placebo. So if they didn't get the vaccine, they still got an injection, but it was saline and basically some kind of placebo medicine. And this was what was called a double-blind study. That means that neither the patients in the study or the physicians or providers who were doing the actual medical care had any idea as to whether they had gotten the vaccine or the placebo, because that way no one was biased about reporting of side effects or anything. And so after people got the initial study drug, so either vaccine or placebo, then every 6 months for 4 years, they had a pelvic exam along with a pap smear and then blood work to look at their antibody response. So looking at the actual data here, this vaccine was given to almost 8,000 women, and an additional 8,000 or so were in the control group. So we're talking about somewhere around 15 or 16,000 women total. And looking at cervical precancer, only 2 cases in the vaccine group as compared to 110 in the folks who got the placebo. And so that's an effectiveness rate of 98.2%. And we see similar things with vulvar or vaginal precancer. So again, around 8,000 women in each group, no cases in the vaccine group for 100% effectiveness rate. And then genital warts was used frequently in these early trials because it's an early marker. So whereas precancer might take months or even years to develop, genital warts will start to develop within a few months after you get the infection, if you're unlucky enough to get it. So that was used frequently as an early marker for how effective the vaccine is. So again, 99% effective. So gosh, that's pretty awesome data. Looking in men then, so these numbers in men are a little bit smaller, but we also looked at vaccine effectiveness in men at 4 years. Again, this is some of the very initial data that came out. And in men, we looked at precancers of the penis and anus as well as genital warts. And again, we're seeing good effectiveness, so 100% effective against precancers of the penis, and then around 80 to 90% effective at preventing anal precancers and genital warts. One of the common questions I'll get is, well, why the heck do we give the vaccine so early? People will say, well, my kid's not going to be sexually active until college, so why do I need to give it to my 11 or 12-year-old? One main reason is we want to make sure to give it before they have any sexual contact. We know that average age that people start having intercourse in the U.S. is around 16, so we do want to make sure we're giving it prior to that time. But also we know from the initial studies that the actual vaccine is more effective the earlier you give it because people have a higher antibody response. So I have to back up a little bit and talk about how those studies were done in order to explain that. But they did something called antibody bridging studies. So if you remember me talking about that college age cohort and the women getting every 6-month pap smears, once we determined that was effective, we then wanted to study younger teenagers, so teen girls 14, 15 and as early as 11 to 12, but you can't really do every 6-month pap smears on a 12-year-old. At least there's not any medical ethics review board who's going to let you do that study for good reasons. So what they did instead was they skipped the pap smear part and did just the antibody studies, so drew blood from those patients every 6 months to check and see, well, hey, do they have the same antibody response as that initial college-aged cohort? And what they found was really impressive. So looking at this data, this is the age at which the vaccine was given. So everywhere from age 9 was the earliest, all the way up to age 23. This was the group in what's called the efficacy program, so they had both the pap smears plus the antibody levels. And then this is the younger group who didn't get the PAPs, they just got the antibody levels checked. And these are the actual antibody levels. So the higher your number here, the higher your antibody response, or the better your immune response against the virus. And so if you look at this, gosh, they have a good response here in this initial group, but then the earlier you give this vaccine, the higher your antibody response. So that's actually pretty amazing, and we think that has something to do with how well the immune system is working when kids are 10, 11, 12. And we do know that protection lasts at least 8 to 10 years. When this vaccine first came out, there were some concerns about, well, it hasn't been studied that long. How long does that protection last? We know for sure that those high antibody titers are lasting at least 8 to 10 years. So you can be assured that if you're giving your child the vaccine at 10, 11, 12, it's going to last them until they're at least college age. And the actual antibody levels seem to be staying the same. They're not drifting downward. So we anticipate it to last for quite a while. And there are multiple studies still ongoing to look at even longer term than that. I think this is the last slide that I have here, and it's just looking at just a little piece of data from the U.S. as to how is the vaccine worked here, and how effective is it in the general population in the U.S. So this is from something called the NHANES study. It's the National Health and Nutrition Examination Survey, and that's a nationwide study that's sponsored by the U.S. government that does both surveys and physical exams and tests to kind of assess the overall health of the nation. So they're looking at things like not just HPV, but also nutrition and dental health and obesity. But one of the things that they've done for a number of years now is that they've checked for the rates of HPV, these types of HPV, in women in cervical vaginal swabs. And so what this is looking at is these are the 4 years before the vaccine was approved, and then these are the 4 years after the vaccine was approved. We don't see much difference here in these older age groups because they probably didn't, there's probably not many women in there who got the vaccine at all. But this age group, this is where we really started to push the vaccine. And you can see from prior to the vaccine being approved to the 4 years after, a 56% decline in the prevalence of HPV. So that's pretty impressive given that we're actually not doing a great job at vaccinating people. Lindsey will talk about that in a minute. But even though we're only vaccinating, less than half of the people who need to be vaccinated, we're still seeing a huge decrease. So to think about what a decline we would see if everybody actually got vaccinated is pretty impressive to think about. And with that, I will hand it over to Dr. Geier.